Good afternoon. I'd like to welcome everyone to Medicine Grand Rounds. Thank you very much for coming. Today, we are honored to have a guest speaker from the University of Kentucky. I'd like to welcome Dr. Sami El-Dalati. Dr. El-Dalati is an expert and recognized leader in putting together models of care for patients with infective endocarditis. Dr. El-Dalati trained at the Ohio State University College of Medicine, and he completed his training in internal medicine and pediatrics, as well as a fellowship training in infectious diseases at the University of Michigan. There is where he helped lead a team-based model for infective endocarditis, and he's now the director of the Multidisciplinary Endocarditis program at the University of Kentucky. So please help me to welcome Dr. El-Dalati.
Thank you, Dr. Cowan. Appreciate the warm introduction, and thank you for having me here as well. All right. It's not the best microphone for a tall person, but let me go ahead and get started. So I'm going to talk a little bit about the multidisciplinary care of patients with endocarditis. I have no financial disclosures. Our objectives today, we're going to talk a little bit about some of the challenges associated with caring for patients with endocarditis, describe the improvement in mortality and other clinical outcomes that are associated with implementing an endocarditis team. I'm going to talk a little bit about our program at the University of Kentucky and how we fund it and support it. And then I'm going to touch on a few other topics, briefly talk a little bit about our approach to tricuspid valve endocarditis and some of the data behind that approach. And then just briefly touch on partial oral antibiotic therapy for endocarditis. So as Dr. Cowan said, I did my training at the University of Michigan. I did my residency in medicine and pediatrics, and I did adult ID fellowship there. And it was there that I first got interested in that topic. And so I'm going to start by sharing kind of a patient story, which was sort of the inspiration for this whole project. So this was a 40-year-old patient who went to an outside hospital with chief complaint of fevers. He had a past medical history that was pertinent for a bicuspid aortic valve, and he'd had a mechanical aortic valve replacement about 3 years before his presentation. And he also had hypertension, hyperlipidemia, and obesity. But so he goes to this outside hospital with fevers. He also has some chest pain, nausea. He's noted to have a cool right fourth finger. And he gets a CT chest while he's there. And it shows fluid circumferentially encasing the ascending aorta, measuring 7 by 7 by 8 centimeters. And there's concern that maybe this represents periaortic abscess. And so because of his history with the mechanical aortic valve, this presentation, our hospital is contacted for transfer, and he's accepted, and he's transferred, blood cultures are collected, he's started on broad spectrum antibiotics, and cardiac surgery is consulted. As well as infectious disease. And he's initially admitted to the ICU. So on admission, he has a transthoracic echo. His EF is a little bit reduced to 35%, but there's no vegetation seen. But all three blood cultures are positive for MRSA. And CT surgery asked for a dedicated CT of the aorta to further characterize the fluid collection. And at this point, their recommendation in the chart was it's unclear whether the patient has an infection around his graft, as they've seen this type of collection occur with the use of a specific type of glue when doing aortic surgery. And so they want to get some additional information. He ends up getting a transesophageal echocardiogram, and in the goal text, you can see there's the graft is seen with surrounding soft tissue density and liquid density material concerning for paraprosthetic infection or possibly an anastomotic leak. But again, no evidence of vegetation. And so ID is involved, and their notes say, they're very suspicious for MRSA aortic valve endocarditis, and the key will be getting source control, and without it, the patient has high risk of morbidity and mortality. And so what we see kind of play out over the next couple of days is this back and forth in the medical record between the ID physician and the CT surgery team. So ID saying if surgery is going to happen, it's best to do it sooner rather than later. Cardiac surgery is still saying the fluid looks simple. Maybe this could be related to some postoperative changes, and they want some more information. And this back and forth just plays out over several days. Ultimately, the request is to get a PET scan. ID is still continuing to say we need surgical source control. But at no point does it appear that the physicians ever actually pick up the phone and speak to each other about what's going on with this person. So ultimately, the decision is made to go and sample this fluid to try to prove whether or not it's infected. And while we're waiting on the results from that procedure, the patient becomes acutely hypoxic. He ends up developing hemoptysis and is intubated. And then shortly after, unfortunately, has a PEA arrest. And during the arrest has continuous pulmonary hemorrhage with clots evident on suctioning. And he passes away. And on autopsy, as most of you probably suspected, he was found to have prosthetic valve endocarditis with infection extending through the aortic annulus into the periaortic graft abscess, and then into the right lung middle lobe, which was the cause of the pulmonary hemorrhage. And he also had numerous infarcts to multiple organs and evidence of heart failure. And so this was a case that ultimately became an M&M at our institution. But what I'll say is that this was very typical of the patients that were transferred to our Center for Endocarditis. As residents, we would take care of them. And we were kind of tasked with trying to coordinate with all these different specialties. But there was never really a great plan. And it was not clear that people were communicating with each other. And so when we presented this M&M, we were kind of left with this question of why did we fail? Here we are, a tertiary care center. We have all the right expertise. We have all the resources at our disposal. Why did we have this outcome? And the reality was that even though we had all these experts, everybody was operating kind of in their own silos of care. So you have cardiology, you have CT surgery, you have ID, you have neurology, and you've got a hospitalist or a resident at the center taking care of the patient, but nobody's really talking to each other. And what that leads to is confusion and inaction. And that was ultimately what happened in this particular case. And so what it amounted to really was a system failure. The model of care that we had set up to take care of patients with endocarditis was not an effective model. But this was just one individual case. And so, this question comes up, I'm sure anytime there's an M&M presented as well, is this the exception or is this the rule? And so what we set out to do was to try to, figure out, is this what happens to the majority of our patients? What does the data show? So around this time, this was in kind of 2015, 2016, this was the epidemiology in the US for endocarditis. So the data around that time, about 43,000 cases per year in the US. In-hospital mortality was 15 to 20%. We hadn't really seen, there wasn't much data that was reflecting the rise of the opioid epidemic quite at that point. So we hadn't seen as much of that impact in our patient population. But one of the big challenges is because this group is so sick, there's a lack of randomized controlled trial data that complicates patient management. And I like to give this as just to put some perspective on the issue. We think about endocarditis, 40,000 cases a year in the US. And if you think about HIV, where there's a number of resources available for caring for that patient population, there's about 34,000 new infections a year in the United States. And so not to say one disease is more important than the other, but just to highlight that there's a lot of resources available to caring for that patient population. But then here's a population that's incredibly sick. There's actually more new cases per year, but we don't have those resources, right? So there's a lot of challenges in caring for them. So when we look globally, around this time, the mortality was about 15 to 20%. And when we went back and looked at our data at Michigan Medicine, as it's called, we found there really was no data. There was no existing registry or database of patients with endocarditis. We had our Society of Thoracic Surgeons database, but that only looked at patients who had surgery. We didn't really have a sense for how our outcomes compared to national numbers, how often we were operating on patients, what the mortality was like for surgical versus medical management, and was there kind of consistent documentation around the decision-making process. So what I set out to do was just a 1-year kind of retrospective review of patients who were admitted to our institution with endocarditis. And we just used an internal research tool called Data Direct. And we pulled using ICD codes that were used in other kind of national studies as our template. I looked at cases in the academic year 2014 to 2015. We had 179 total charts that were pulled, and then after reviewing them, whittled that down to ultimately 68 cases of definite endocarditis. And we elected to just include patients who had at least one indication for surgery per the 2015 American Heart Association guidelines, because we really wanted to see what's the interplay with all the different specialties for patients who need surgical management or may need surgical management. And I'm sure many of you are familiar with this, but just briefly, those 2015 American Heart Association guidelines for surgical indications for left-sided endocarditis, class 1 indications, valve dysfunction resulting in signs or symptoms of heart failure, endocarditis caused by fungal or highly resistant organisms, or causing heart block, annular aortic abscess, or destructive penetrating lesions, and then evidence of persistent infection, which is usually manifested by persistent bacteremia or fever greater than 5 to 7 days, provided other sources of infection have been addressed. And then the class 2 indications, more relative, tend to have are more related to the size of vegetations and the presence of recurrent emboli despite appropriate antibiotic therapy. So of those 68 patients that we looked at, we found that the overall in-hospital mortality was quite high, 29.4%. So almost double what was being reported nationally. And this just kind of graphically demonstrates that. But then what we found when we looked closer was that a full quarter of these patients didn't have a documented cardiac surgery consult. So 15% of patients had no consult placed at all, and 10% had a consult placed, but then there was no documentation of their recommendations. And not surprisingly, the mortality for those patients was higher, 47%. Of the remaining 51 who did have a consult, about half were managed medically, and you can see their in-hospital mortality was quite high, almost 40%, and the 2-year mortality was 65%. And then for the patients who had surgery, they had much lower in-hospital mortality, and that was statistically significant, and the 2-year mortality was also statistically much lower, 20%. We found the mean time to consult from admission was 7 days, and then it was another 7 days from the time of consult to an operation. So it was a little over 2 weeks before they were getting their definitive management for their underlying issue. Now, obviously, there is going to be some selection bias here, and patients who are getting surgery are probably less sick. And when we went through and looked at, broke down the groups, that was what we found. So patients who were medically managed were more likely to have been started on dialysis acutely during their admission. They're more likely to be in the ICU, have Staph aureus as their pathogen, more than 2 indications for surgery, and higher STS risk of mortality, greater than 8%, which is considered high by the STS. So generally, the patients were sicker, and that was a big part of why they were not offered surgical intervention, just a high risk of perioperative mortality. That was the most common reason. You'll see the second most common was continued injection drug use. And then there were smattering of others. Sometimes it was not clearly stated. But then when we broke it down a little bit further and we looked at the outcomes for the critically ill patients, what we found was that the sickest patients, when they did undergo surgery, tended to do better. So patients with higher STS risk scores, patients who are in the ICU, on vasopressors, intubated, or all three, tended to do better when they underwent surgery. And this was all statistically significant. So, our take home from this was, all right, the in-hospital mortality and 2-year mortality was significantly improved for patients who had surgery. Critically ill patients are often not referred for or offered surgery, but may still benefit. Clearly, there was some room for improving communication between providers, and then there are probably some other unidentified factors that are contributing to higher patient mortality. So we had this data that showed we really weren't doing a very good job caring for these patients. And the question we were left with was, well, how can we do better? And that was an overwhelming question for me at the time. We didn't really have a straightforward solution for how we were going to try to tackle this. We set about doing kind of a QI type analysis, and here's our little fishbone diagram. I won't go through all of it. The point here is just, as everybody who's taking care of a patient with endocarditis knows, there's so many ways that things can go wrong. And many of these patients are transferred. So it starts from delayed diagnosis at the outside hospital to delayed transfer to delayed surgical evaluation or intervention, and then lack of follow-up afterwards. All of those things are going to lead to an increase in mortality. Maybe they're not on the right antibiotics. All these things have this interplay. And so this was, quite overwhelming to think about, okay, well, what's one intervention that's going to try to tackle as many of these issues as possible? And as I was kind of struggling with that, I came across this paper that was published in 2009 by a French hospital. And they looked at their outcomes for endocarditis patients after they implemented sort of the multidisciplinary team approach. And around the same time, our hospital was working on a PE response team. So there was a little bit of interest in this. And that was sort of how I came across this, was just trying to see if there was anything analogous to that in endocarditis. But their study, what they found was, so they looked at between 1991 and 2002, they just looked at the outcomes for endocarditis using their standard model of care, which was just kind of ad hoc consultation. They found the 1-year mortality was 18.5%. And then in 2002, they implemented an endocarditis team with infectious disease, cardiac surgery, cardiology, neurology, and then they tracked their outcomes going forward. And what they found was over the next 4 years, their 1-year mortality fell dramatically by over 10% to 8.2%. So it cut in more than half. And so now, instead of everybody operating in their silos of care, you have this multidisciplinary and interdisciplinary team where everyone is communicating, and you've got the patient at the center, but everybody's come to the table and is working together. And actually, this team model was included in the 2015 European Society of Cardiology endocarditis guidelines. So it's crazy, this is almost a decade ago that this is coming into their guideline, and they make recommendations about these teams meeting on a regular basis to decide who should have surgery, what antibiotics they should receive, and for how long, and also recommend participating in national registries and publicly sharing outcomes so that this data is available. But this recommendation was not included in the 2015 American Heart Association guidelines. And so that adoption had been much slower, at least in the United States, and not many people at our institution were really even aware of this kind of process or data. So seeing this was, I think, in my mind, seemed like the best option to try to address as many of the issues that we identified as possible. And so we set about trying to start our own team. So just to kind of walk you through the timeline, December of 2016 was when I finished doing that chart review study. Or started doing that study and finished it in September of 2017. And then we presented that patient's case as our M&M in November of 2017. And that started to galvanize some support that, okay, we need to do something different here. And what helped was that, okay, well, we have this one individual case, but then we also have data that shows that it's not just one particular case. This is happening frequently. So after that M&M, we had kind of a planning meeting with a couple of the faculty speakers who were at the session. We had a CT surgeon, we had 2 cardiologists, an ID faculty, and it was myself and one of my co-residents were the ones who were trying to push this forward. And so then over the next few months, went and presented to the different faculty groups about the idea, presented our data to cardiology, infectious disease, cardiac surgery, and essentially just tried to see what the level of interest would be in doing something like this and if we could recruit faculty. And we were able to get a couple people pretty much from each division. Now, there wasn't overwhelming support. We had no funding at the time, so it was all going to be voluntary, the participation. But our approach was, well, we only really need 1 or 2 people to start it. And once we start, then we can try to get more involvement and more buy-in. And so by May of 2018, we had enough people that we could have our first meeting. And our first month, we met weekly, but we worked on developing kind of our own protocol that we were going to try to follow. How were we going to approach the patients? When did we want to have the teams consulted and so on? And then by June of 2018, we started presenting our first cases. And so we had developed our protocol. We had it added to the hospital's We had an antimicrobial stewardship page with recommendations for antibiotics for endocarditis, among other diseases, and we kind of added our protocol to that so everybody could have access to it. And we also developed a best practice advisory. So we had Epic there. So it's just a little alert that came up whenever diagnosis of endocarditis was entered into the patient's chart, and it would encourage cardiac surgery consultation. And then, we had our group. So June 2018, when we started presenting cases, we had 3 ID specialists, 2 CT surgeons, 2 cardiologists, 1 stroke neurologist. We had the PA from cardiac surgery who did all of their consults, and then we had an ID pharmacist. And then we documented the team recommendations with notes in the electronic medical record. So it was brief. It was usually just a couple paragraphs, just summarizing the discussion of the team and what the next steps would be. So in our first year, we presented 119 cases. The way we gathered the cases was primarily from the infectious disease consult service. What we had found in that initial study was that ID was consulted in 99% of cases. So we thought that was probably the best way. And as alluded to before, we had a previous mortality of 29.4% and that national number of between 15 and 20. In our first year, for those 119 patients that we discussed, the mortality fell to 7.6%. Now, we were presenting all comers with endocarditis, so this was not just patients with surgical indications. Some of these patients had possible endocarditis by Duke criteria. So we tried to look at, compare the groups a little bit more analogously. So when we looked just at patients with definite endocarditis and surgical indications, we had our initial group, the 68 patients in 2014, 2015, with the almost 30% mortality. And we had 56 patients in 2018, 2019, and that mortality had fallen to 7.1%. And that was statistically significant, not surprisingly. We also found that the proportion of surgeries being performed did increase, although it wasn't significant. So we went from about 41% of those patients getting surgery to 55. We saw the average time from admission to surgery decreased by about 2.5 days, but that was not statistically significant. We did see that the length of time prior to a CT surgery consult fell significantly from 7 days to 2. So we were getting them involved earlier. And obviously, if you can get to the patient before they've been in the hospital and deteriorating for a while, there's more opportunity to try to intervene. But one of the things we found, because I think there was probably some bias in our group, with the feeling was, well, you're going to do more surgeries and that's why everybody's going to do better. But what we found was that the medically managed patients actually seemed to benefit the most from the group. So the patients who were medically managed, of the 68, 45% had passed away in hospital previously, and we got that down to 16%. So it's still high, but much, much lower. And then because the surgical outcomes were already quite good, even though we did not have any deaths in our surgical group after the group was started, that was not a statistically significant change. We also saw that just the total number of surgeries being done for endocarditis increased by almost 50%. We went from an average of about 36 per year over the 4 years before the group up to 52 in the year that we had the group. And then we did a propensity matched analysis so we could try to control for any as many variables as possible, as this was obviously not a randomized control trial. And what you can see here was that actually the benefits were more noticeable after the propensity matching. So the discrepancy in in-hospital mortality was greater. The discrepancy in mortality for the medically managed patients was also greater. Really, the only thing that we didn't see a big difference is was the time to surgery actually came a little bit close, approximately the same, about 11.5 days. But what we found was that the team changed the plan of care in almost 85% of all patients. The most common was a change in the antibiotic plan. So we found, there'd be many patients who may have kind of a vague history of a penicillin allergy. And as a result, they were perhaps on like the 3rd line antibiotic for their particular organism. And so we were really aggressive about having allergy see those patients, desensitizing them, getting them on their 1st line treatment. But almost a quarter of patients had a change in their surgical plan. We also recommended additional imaging, infectious workup. but a large number of patients had some type of change. And we ultimately published this data in the Annals of Thoracic Surgery back in 2022, entitled The Clinical Impact of Implementation of Multidisciplinary Endocarditis Team. If you want to kind of read the data in more detail, I encourage you to check it out. But over these last couple of years now, there's been, I think, a little bit more of a push, especially in North America, for these multidisciplinary teams. There's a recent meta-analysis that was published by a group in Montreal about a year ago that looked at the impact of these teams and programs on patient outcomes. They had 18 total studies, 15 that they ultimately included in the meta-analysis. But the meta-analysis resulted in a risk ratio of 0.61 for mortality in favor of a dedicated multidisciplinary team as compared with usual care. So now there's enough literature out there that it's not just one or two institutions, but we have a meta-analysis that shows that there's a clinical benefit for patients. Of the 18 studies, 16 reported a decreased time to surgery, and 13 reported increased rate of surgery after implementation of a multidisciplinary team. But they highlight, further research is needed to evaluate the benefits of sort of virtual team models of care, cost effectiveness, and the impact on patient-reported outcomes and long-term mortality. Most of these studies have looked at in-hospital 90-day, 1-year mortality is kind of usually the limit. But now the European Society of Cardiology, they have released their most recent guideline in 2023, and they've really focused quite a bit on the role of these multidisciplinary teams. It's a really, great document in that they go through in a lot of detail and talk about who should be involved in the team. They make a class 1 recommendation that patients who have complicated endocarditis should be referred to a heart valve center with an endocarditis team. And that for patients who are not referred, that there should be communication between the referring hospitals and the centers that have these teams to try to improve care. Again, they highlight who are the core members of the team, what are some of the adjunct specialties that can be involved. And now, somewhat belatedly, but the American Heart Association has adopted this recommendation for multidisciplinary endocarditis teams. The STS has now adopted this, and then obviously the European Society of Cardiology. And so I want to shift gears a little bit. This was the background of how I got interested in this, and this was the data from our group at the University of Michigan, but obviously I'm not there anymore. And so I'm going to talk a little bit about what we're doing at the University of Kentucky and how that came to be and how we're trying to support it. One of the challenges we had in Michigan was that we were never able to really secure long-term funding from the institution to keep things going, and that was a big part of why I left, was to try to pursue this elsewhere. So as I mentioned earlier, the time where we were looking at a lot of the data in Michigan, we hadn't really been impacted or seen the data be impacted by the opioid epidemic. Now, over the last 10 to 15 years, the epidemiology, particularly in Kentucky, has changed quite a bit. So nationally in the U.S., the total number of cases has stayed similar. In-hospital mortality has decreased a little bit to around 11%, but the proportion of cases caused by injection drug use have increased quite a bit, from 16 per 100,000 to 22 per 100,000 over that 2003 to 2016 time span. And we were particularly hard hit by this in Kentucky. So Kentucky is considered part of the Appalachia region of the United States. So Kentucky, West Virginia, Western Pennsylvania, Southeast Ohio, parts of Virginia have been kind of hardest hit by the opioid epidemic. There was a lot of overprescription of opioids in that region. And so looking at the epidemiology at our institution, this was a study we published a couple of years ago that looked at this 10-year period between 2009 and 2018. So it's broken down into 5 2-year periods. So period 1, 2009 to 2010, you can see we had just 86 total cases of endocarditis at our institution, and about 38% were caused by injection drug use. By the end of that 10-year period, 2017 to 2018, that had exploded to 505 total cases of endocarditis, and nearly 3/4 were caused by injection drug use. And endocarditis actually comprised 0.62% of all admissions to our hospital during that 2-year time period. So we were really kind of overrun with this disease. So we set out to start our team in 2021. That was when I first arrived there, and we've expanded beyond sort of the initial team members. So we have some of the core ones: cardiac surgery, cardiology, infectious disease. But we have an addiction consult and education service. That's what ACES stands for, which we did not have in Michigan. We've got a neurologist and 2 neurosurgeons that are part of our team. We've incorporated palliative care. We also have physical medicine and rehabilitation as part of the team to help with those patients who need that longer term rehab support, physical rehab support. And then we have ethics and social work too. So our first meetings were in July of 21. And then similar to Michigan, we kind of created our own institutionalized protocol and talked a little bit about how the group would function. And then we started presenting patients in September of 2021. We meet weekly on Wednesdays from 4 to 5 p.m. By Zoom. We have an in-person option, but it's usually most convenient for people to do it over Zoom. And we discuss all of our inpatients admitted with endocarditis. So we, at tertiary care center, we have about 1,000 beds at our main hospital. And then we have a smaller satellite hospital that's about a mile down the road that has another approximately 200 beds. So we'll also present patients who are admitted there. And since we've started, we've discussed over 500 patients, 527 since September of 21, and just a little over 3 years. But one of the things that we did that was a bit novel is we created a separate ID consult service just to see patients who had endocarditis and cardiac device infections. One of the things that we found in Michigan is that we were a pretty big ID group. We had about 25 to 30 faculty who would round on service and see patients. And they had a lot of great expertise, but one of the challenges is it's hard to get 30 physicians who are going to have the exact same plan for a patient or the same perspective. And so it made it really hard to kind of finalize plans. The teams would switch and then the antibiotic plan would change. And so it created a lot of difficulty there. So the idea behind this was we would have a core group of 3 or 4 people who would round on that service, and we'd all kind of communicate regularly and try to standardize our approach as much as possible. So it's generally staffed each week with 1 attending and an advanced practice provider. We do have fellows that rotate with us and medical students occasionally. But then in addition, we have a nurse navigator, as well as a social worker and pharmacist who are all part of the team. And we all round daily together. We usually will do a table round with everyone, and then we'll go and see patients. And then what we do on Fridays is we have a weekly meeting with the new attending who's coming on to talk about the plans for the patient. So if there's any concerns or questions, ideally we talk about them then, and that way we try not to change the plan when the attending switch. And like I said, we have opportunities for learners to rotate with us. So as part of our team, we have a nurse navigator. I'll shout out her name's Deb Gill. So she has been with us about 2.5 years and is incredibly important for kind of the day-to-day operations of the team. So she sends out the list of the patients that we're going to present the day before to all the team members. And she works really closely with the patients post-discharge. So she helps to coordinate their follow-up appointments. She does follow-up calls for all patients within 48 hours. She's their point of contact. We have business card with our office number and her direct line so that they can call her if they need anything. She calls them for appointment reminders, coordinates outpatient testing, works really closely with the other support staff from the different specialties. And then she works really closely with our pharmacist and our specialty pharmacy to help with hepatitis C treatment. And I'll talk about that here in a second. But her position is funded through the infectious disease division. So we're fortunate our division chair agreed to kind of fund this position to help support the consult service and then the team overall as a whole. We do have a dedicated pharmacist, as I mentioned, and we've just been in a little bit of transition. The person who was with us at the beginning left, but they're and just have a replacement that started. But their main role is that they help with dosing antibiotics, selecting the regimens, helps with our patients who are on OPAD or the outpatient IV antibiotics, helped develop our oral antibiotic protocol, which I'll get to, and then again works with our nurse navigator around the hepatitis C treatment. And it may be different here in terms of the model for hepatitis C, but the challenge that we run into is that hepatitis C medications have to be dispensed through a specialty pharmacy in the United States. They're very expensive, so hospitals will not carry them on the inpatient formulary because they can't get reimbursement for them. So we can't start folks inpatient. So we work really closely with our specialty pharmacy so that patients can start treatment essentially right as they're discharged. And with that kind of model, we've had 79 patients that we've been able to link to treatment. But the key with this hepatitis C, why I bring it up, is that was how we were able to justify funding the position, was because the hep C treatment brings in a lot of money to the pharmacy, the College of Pharmacy. And so they were willing to fund that position because of that income. And then, so in addition to the hep C role, the pharmacist also, can round with our team and do those things. So that's kind of, the backbone of our team. I wanted to shift a little bit. We've talked about our team, who are the team members, but because we have this group now, we've been able to kind of focus in on a couple of different areas where there's not a lot of data and try to hone in on what are the best strategies. And so I wanted to talk a little bit about tricuspid valve endocarditis. And so this is a table from that same study that I had alluded to earlier about our epidemiology, where we went from the 86 cases to 505. But you can see that the number of isolated tricuspid valve cases increased quite a bit. So we were at about a quarter of the cases initially were tricuspid valve, and then that increased to over 40%. But just because of the massive increase in volume, that was over 200 cases in that last 2-year period. And the question is, as I'm sure you struggle with too, is kind of what's the best way to manage these patients? Angiovac has become this popular tool to try to kind of stabilize patients, remove the vegetation, and maybe delay performing a valve surgery. But there's really not great data to support it. So our institution had been doing it since about 2017, but really without any sense of how the outcomes for those patients compared to medical therapy or surgical therapy. And you can see even in the most recent European guidelines, there's really not, this is all they say about it, is that they say recently interest has been generated in the extraction of large vegetations using percutaneous extracorporeal circuitry for aspiration. The main goals have been debulking of septic intracardiac masses, reducing the infectious load, and achieving clinical stability, but no comment about the outcomes or how it compares or whether you should do it or not do it. And they give kind of a 2B recommendation for considering it. So we went back and decided to look at all of our patients who had angiovac versus medical therapy and surgical therapy and look at kind of the outcomes. So we had pulled all of the patients over approximately 7-year period and ended up with 215 total, 100 who had medical therapy, 66 who had angiovac, and 49 that had surgery. And what we found was that the mortality at 30 days and at 1 year between the groups was actually quite similar. So you can see medically managed patients had a 6% 30-day mortality compared to 6.1 for angiovac and 2% for surgery. And then 1 year, that was 9% for medical versus 15% for angiovac and 4% for surgery. And when we did the Kaplan-Meier curves, there was no statistically significant difference between the 3 treatment strategies. So, in that study, we highlighted that there was this lack of difference. But one of the things we also found was that addiction medicine consultation was associated with decreased 1-year mortality in patients who had drug use associated tricuspid valve endocarditis. So we set out to kind of develop an approach to these patients using this data to help inform us. And we actually just published this paper a couple of months ago that was kind of highlighting the management of acute drug use related native tricuspid valve endocarditis, arguing that this maybe should be a non-surgical disease. So this was a review article that we wrote, but then we also have a companion piece of 72 patients that we managed using this approach. So our model that we've kind of adopted for these patients is we make the diagnosis, we get our ID endocarditis consult service involved and the endocarditis team. And then if the patient has substance use disorder, we'll bring in addiction medicine. If the patient is persistently bacteremic for greater than 48 to 72 hours, and now that's different than what you might see in a lot of studies that may say, 5 to 7 days. We tend to be more aggressive here, but we'll evaluate for other undrained foci of infection, and we'll start combination antibiotic therapy for patients who have Staph aureus bacteremia. So if it's MRSA, it's daptomycin ceftaroline. If it's MSSA, there's data for the use of cefazolin or nafcillin with ertapenem. And with that approach, we've been able to clear patients' bacteremias quite effectively. If the patients still remain bacteremic, then we'll have a multidisciplinary discussion about the risk benefits of percutaneous mechanical aspiration. If we clear their cultures, then we kind of just continue down the medical therapy approach. And if the patient is stable and they have an organism that's eligible for oral antibiotics, which I'll touch on here shortly, then we'll evaluate for pursuing oral antibiotic therapy as an outpatient. But then what we do is we follow all of our patients in a multidisciplinary clinic to assess for whether they're going to develop hemodynamic indications for surgical tricuspid valve replacement. So RV dilation, symptomatic heart failure, these are the things that we're monitoring them for. And so they'll come back, they'll see me, and they'll see one of the cardiac surgeons. And this gives us an opportunity to really treat their substance use disorder and kind of reassess where they're at. We'll also talk with them a lot about whether or not they're able to take warfarin, and we'll have the discussion about what's the best valve option for them, whether it's a bioprosthetic valve or a mechanical valve. So adopting this strategy, we've had, as I mentioned, we have this companion piece that we just published. So we had 72 patients where we took this protocol and applied it. 66 ended up being managed medically. We had 5 who had the angiovac procedure done. And then 1 had a tricuspid valve replacement and a PFO closure because they had systemic emboli across their PFO and also significant shunting. So we had 1 surgical patient. But over half of the patients had indications for tricuspid valve replacement per the American Heart Association guidelines. And that was compared to, in our previous study, about a quarter of patients. So we had more people who had indications for valve surgery in this study than we had in our study looking at angiovac. Notably, over half of the patients were transitioned to oral antibiotics. And what we found was that our in-hospital mortality was quite low. We had 1 death in a patient who had a prior patient-directed discharge and presented in multisystem organ failure. We had 1 additional death at 90 days, and that patient unfortunately had refractory B-cell ALL, who passed away from complications of that. And then we were able to follow 60 patients to 1 year. We had 5 deaths out of the 60 at 8.3%, but we had the remaining 12 patients were still alive but had not reached 1 year post-discharge. So it seemed like our approach here was we had low in-hospital mortality, we had low 90-day mortality, even with this medically managed approach. And so that's been kind of our shift is to really try to treat the patients aggressively, medically, treat their substance use disorder, bring them back to in a multidisciplinary fashion to follow them up, and then replace their valve in that kind of more elective setting. And in that study, I forgot to include this, but we've had 14 patients who have since come back and had their tricuspid valves replaced down the road. I'll just briefly touch on oral antibiotic therapy. We had over the first year of our team, we tracked our patients that received PO antibiotic treatment. We developed a protocol that was adopted from the POET trial that was published in New England Journal of Medicine in 2018. And we published this case series of our first 32 patients. We had very low treatment failure rates. We had 1 relapsed infection at 90 days. We had 1 death at 90 days. And so our experience with this has been very encouraging. I'm going to be talking a little bit more about this tomorrow at the Canadian Cardiovascular Congress. But having this team model really allows us to do this oral treatment, we have the nurse navigator who can follow up and coordinate with them. And then we know we can bring the patient back quickly to see cardiology or cardiac surgery if there are other issues that develop. So the last little bit here, I'm just going to touch on some of the other things that we're doing in addition to our weekly conference. I mentioned we have this multidisciplinary follow-up clinic that's done with myself and one of our surgeons. It's 1/2 day per month. It allows the patients obviously to see both providers at the same time. Our ID department has a little bit of funding where we can help with transportation for patients, so we can use that to get them in to see the surgeons. And as I said, this has become kind of our primary clinic for complex endocarditis patients who maybe aren't going to get surgery initially, but need that longitudinal follow-up. And then many of our patients come from Eastern Kentucky, which is a very rural, remote area. And so in February of this year, I started doing an outreach clinic in a town called Hazard, Kentucky. It's about a 2-hour drive. So I go out there, and I can see patients who live in that region. About 1/3 of our patients come from counties that are considered in Eastern Kentucky. So this just makes it a little bit easier for them to follow up. And then we've been trying to do more regional outreach with the referring hospitals. We've done the last 2 years this endocarditis virtual summit. It's kind of 4-hour virtual conference where we talk about our team and also just talk about some of these different approaches that maybe some of these institutions can use, and especially with respect to aggressive IV antibiotic therapy up front, who needs to be referred for surgical considerations, how to approach patients who have substance use disorder. And then we are planning a 3rd summit for this February, and this is just all going to be online, and it's open to anyone. There's no enrollment or registration fee. So if anybody's interested, that would certainly be welcome. And so our team now, we haven't published this data, and I haven't been able to do advanced statistical analysis on it, but I just wanted to share a little bit of what our outcomes were like. So that previous study, 2017, 2018, we had the 505 patients. Over the first about 3 years, we've got 501 patients who are into our endocarditis database. And you can see again, the inpatient mortality has fallen at Kentucky as well by about 7.5% from 17.4 to 9.8. We've seen the rate of surgery increase quite substantially. And then the median length of stay has fallen from 25 days to 17. And a large part of that has been the transition to oral antibiotics. So I like to share, at the end, we had just as a comparison to our initial patient. So we had a 26-year-old female who came in similarly with fevers. She also had a history of substance use disorder with injection drug use and hepatitis C. And so she came into an outside hospital with fevers, altered mental status, was intubated for respiratory failure, and was found to have tricuspid valve endocarditis with this PFO and right to left shunt. So the patient I alluded to previously. So she gets transferred to us. She's found to also have septic cerebral emboli, no mycotic aneurysm. But we present her at our endocarditis conference. We get one of our interventional cardiologists is able to go in and place a PFO closure device temporarily, which allows the shunt to be relieved and her to be extubated, stabilized, and then ultimately goes for tricuspid valve replacement. The PFO closure device is removed, obviously, because it was placed at the setting of infection, and then they just surgically close it and then completes a course of IV antibiotics. And then gets discharged with our addiction medicine team to a substance use disorder rehab, completes that, and also completes treatment for hepatitis C through our linkage program that we developed, and is still doing well now, almost 2 years later. So an example where an incredibly complex patient who needed a lot of thought, a lot of different specialties involved, is able to have a successful outcome using this team model. And so the take homes for me from this whole process have just been, that sometimes it can take fresh faces to solve old problems. The model of care for endocarditis had been stagnant for years, but people had become really accustomed to it and the inefficiencies. And so we're sort of indifferent to change until as residents, we looked at the problem a bit differently. The data is important. It gets your foot in the door, but it will only take you so far. And the M&M and really presenting an individual person and speaking to everyone's humanity was a big factor in how we were able to get this off the ground. identifying a common goal for all stakeholders and creating solutions around it. I think even though we may all have had different opinions about what the best treatment for the patient was, we all wanted the patient to do well. And so that was something that we really came back to a lot whenever there were disagreements as a team. Have the courage to act without a guarantee of success. We had no funding. We didn't know what the support for this was going to be long term, but we knew that we needed to try something and to try something different. And so we did. And stay grounded in your mission and purpose, and so that you can be resilient to the inevitable obstacles and setbacks that come. And ultimately, it was our hope that we could change things became the foundation of the change. And so with that, I'll close this image of the multidisciplinary team all working together. Lots of acknowledgments. I don't know that I can go through everybody. I always put my mom up here first because she really supported me a lot through this process. There were a lot of nights, where I was really frustrated, and she helped get me through that. But I'd like to really shout out our ACES team, Alyssa Tremblay. She's our the social worker with that team, and Angela Linder. She's their nurse navigator. Who, without them, we wouldn't be able to link all of our patients to treatment. Michael Sakella and Hassan Reda are the two kind of lead surgeons with our group. Talal Al-Nabelsi, John Gurley are the cardiologists. John Gurley does our angiovac procedures and all of our cardiac device extractions. And then our pharmacist, Bobby Joe Stoner, who's been a huge help, and our neurologist, Kara Kennedy. So with that, I'll close. I know I went a little bit over, but thank you again for having me. And if there's any questions.
Thank you very much, Sami. I really enjoyed learning about the journey. As you know, it's something that we're trying to do here at St. Paul's Hospital. And I think you've laid a great foundation for us starting our own journey. So thank you very much.
Yeah, thank you.
With that, does anyone have any questions? Go ahead.
Thanks so much. That was wonderful to hear your experience. I could just hear your passion throughout the talk. I came all the way from Saskatchewan for this talk. Basically, I wanted to ask about your tricuspid valve cohort. I'm just wondering, in your cohort, how many of those patients injected drugs? Was it like 50% like your retrospective data showed? And then my other question was, how many of them are homeless? Like what did you do around that?
Yeah, it's a great question. In that particular cohort, it was much higher. It was about 90% of the patients had injection drug use in that 72 patient series that we published. I don't know the exact percentage of patients who are unhoused. I would estimate it's probably about a third. That is a big challenge for us as well. There's not a lot of great housing resources for patients in Kentucky. So really the best pathway to stable housing for them is to go through a substance use treatment program, because they'll have sober living facilities that they can then transition to. But many of them, don't necessarily want to pursue that option. So then we get stuck. We try to give them all the resources that are available to them in terms of shelters and the substance use treatment, and then kind of have to leave it up to them to decide what they want to do.
Thank you very much for this great talk. I have two questions. One is, I did not see any antimicrobial stewardship or microbiologists on your team. I'm just wondering if those can also add to your great work that you already done in terms of their resources and their expertise. And number two, comparing what you have done so far with success and comparing that behavior of cardiac surgery in terms of saying that the patient is not a case for surgery, is that behavior changed because of your multidisciplinary approach with this, which resulted in more support for surgeon? Was it that based on a subjective criteria, or it was an objective score system that they were saying that patient cannot be surgery in the past?
Yeah, great questions. I do have some of the microbiologic data. I didn't include it just with time constraints, but it's approximately 80% of our endocarditis is Staph aureus, MRSA or MSSA. It's about 45% MRSA, 35% MSSA, and then the next kind of 15% are primarily Enterococcus and Streptococci. And then a smattering of different organisms. About 1 to 2% are gram-negative. And we do work very closely with our microbiology lab. They don't necessarily come to all the meetings, but they help us if we do any additional send-out testing, like PCR from valve specimens. And then in terms of the behavioral change from the surgeons, it's been a little bit different at each institution. So at Michigan, when our group started, we had a new surgeon who started around the same time as our team, who was pretty aggressive and open to operating. And so that I think led to a bit of a culture shift because if other surgeons were saying no, he was taking them, and so there were kind of cases being transferred from one surgeon to another. There wasn't really a lot of use of the STS risk score. It could be a whole nother conversation, but that's kind of the most objective measure we can use for perioperative mortality. We tried to standardize that and include that in our notes, what the risk score was, but that didn't really factor in a whole lot to decision making. I found at Kentucky, I think we have made progress with our surgical colleagues. I definitely think they feel they have more support. I mean, I'm in clinic with them, every month, but then I see ad hoc patients with them pretty much every week, and so we have a strong relationship. I can just say subjectively, we had a surgeon that when we started, he didn't operate on a single patient for 6 months, and now he'll operate on a couple of folks every month with endocarditis. So I've definitely seen the change, at least with that individual.
Congratulations on your great work. Thank you.
Thank you. Yeah, go ahead. Yeah.
I have a slide up there about congestive heart down in the States, do you make people stop intravenous drug use before doing the surgery?
Yeah.
For how long?
Yeah, it's a good question. So most of our surgeons, if a patient comes in with like left-sided endocarditis and they have class 1 indications, if the patient has just been using, they will still operate on them for the first operation. If it's a tricuspid valve case, we usually try to manage those medically up front. It becomes a lot trickier as we get into redo operations. I think most of our surgeons require that the patients not be using intravenously to do a redo operation, unless it's sort of like a life-threatening type situation. But if the patient is stable, it can be managed medically initially, then the preference is to try to get their substance use under better control. I will say our surgeons will operate on folks who are using by other means. So if if they're snorting medication or smoking it, like they're still willing to operate on those patients. So that hasn't been a barrier, but obviously with the injection use, we see really high rates of recurrence. So we really try to cut that down as much as possible.
Any other questions? Any other questions online? Okay. So again, on behalf of the Department of Medicine, as well as the Infective Endocarditis Working Group, thank you very much.
Great talk.
No, thank you.
So, challenging change model of care. So the analogy we have